Welcome to the Feeling Good podcast. I'm your host, Fabrice Nye, and joining me here in the Murrieta studios is the creator of the team model, Dr. David Burns. Hi, David.
Hi, Fabrice. Good to see you.
Good to see you again, yeah. So today we're moving to the third letter in team, T-E-A-M, the letter A, which stands for?
Agenda setting, or we've changed it a little bit recently to call it paradoxical agenda setting to give a distinction between other forms of therapy that think they're doing agenda setting. What we're talking about is really radically different.
Yeah, and also you may need to define this a little bit, because when I first heard the term agenda setting, I thought it was about, well, let's talk about what we're going to do during this session. But it's a little bit different than that. Can you explain?
Well, it's really the advanced calculus of psychotherapy. It's the most magical and powerful tool in all of psychotherapy. And what it has to do with is bringing the patient's subconscious resistance to conscious awareness in a gentle, loving, compassionate, fun way, actually, and then melting the patient's resistance away with a variety of newly developed, pretty powerful techniques.
So what you call agenda setting is really concerned with the resistance aspect of things.
Absolutely.
And the motivation.
Absolutely. And how it links in with my earlier work, helping to develop cognitive therapy, the whole emphasis there was, as we've talked about in prior podcasts, that our thoughts create all of our feelings, positive and negative. It's not what's happening to you, but the way you think. And then cognitive therapy that was ushered in by Albert Ellis in the 50s and Aaron Beck in the 60s had to do with developing powerful techniques to change the negative thinking pattern of the depressed patient or the anxious patient, telling yourself, I'm no good, I'm a loser, things will never get better. And that was tremendous. But team therapy now offers another equally powerful dimension, and it's based on the idea that our motivation has also a very powerful effect on how we think, feel, and behave. And when people don't rapidly overcome depression or anxiety, and by rapidly I mean in a single therapy session, or just say an hour and a half or 2 hour therapy session, complete elimination of symptoms. And when that isn't happening, the most common cause of it is that the therapist has not skillfully or effectively dealt with the patient's resistance to change.
Yeah, and that seems to go along with some research that shows that the client factor is actually predominant. And so therefore the motivation, and that needs to be addressed.
Yeah, yes, although it's not entirely a client factor, because therapists, as it turns out, actually cause therapeutic resistance. They cause the patient.
Oh, how's that?
By trying to help.
Okay.
Helping is the cause of nearly all therapeutic failure.
Oh, well, that puts me kind of in a bind, because that's why I'm doing this job.
Exactly, and that's why therapists sometimes have trouble learning paradoxical agenda setting, because it means changing your identity as a therapist and giving up that compulsion that many, if not most therapists have to jump in and offer help when someone is suffering. And certainly that comes from the goodness of our hearts, but it also triggers resistance in almost every case.
So explain to me, because when somebody comes into my office and they say, Doctor, I'm depressed, they're looking for help, aren't they?
Yeah, absolutely. But the Anthony de Mello, the Jesuit mystic, said, we yearn for change, but cling to the familiar. And that was the thinking as of about 100 years ago, and it's still true today. It's just that we've learned in the last 3 or 4 years, a vast, tremendous new discoveries, and why people cling to the familiar, why people are reluctant to change, why they're suffering. Depression is the worst form of suffering in the world. When I wrote my book, Feeling Good, I talked about a patient who who said every night she went to bed praying that she would die of cancer so she didn't have to commit suicide and let her family down, so she could die with dignity. And so when I first started out with cognitive therapy, it was hard for me to comprehend that anyone would really want to cling to depression or to anxiety or to a troubled marriage or to a habit or addiction. But now we've gone much more deeply into it, and we can see the reasons why people with emotional problems or relationship problems do resist change, and the reasons will be radically different, and kind of a huge surprise to therapists who it's not what they've been taught in textbooks, it's not what they've been taught in graduate school. And the neat thing is not only do we have now new tools for understanding what resistance is, we've got amazing tools for getting rid of it quickly, or reducing it, eliminating it, melting it away, whatever word you want to say. And it is incredibly, incredibly exciting. This Tuesday, I showed another trauma video to the training group, and I was just sorry I didn't get the email to you to come to attend it.
I missed that.
But it was again a woman who'd had horrific traumas in her life, sexual abuse as a girl from her grandfather, and high school dropout, and became kind of a intravenous drug addict, and has had massive traumas and throughout her life, and struggling with depression. At the beginning of the session, her depression score was more above the severe level. It was in the extreme level, and she was extremely rageful and extremely anxious, just the worst that could be. And she tried for years to get treatment for this, and she's still, horrifically in pain. And again, I use the similar techniques that you're familiar with now to melt away the resistance. And it was just fantastic, after I empathized and brought her resistance to conscious awareness and melted it away. And then when we went to the M equals methods part, I mean, she was almost entirely symptom-free before I started using any of the methods. And then when we went to the method, she just blew her negative thoughts out of the water. And she was literally euphoric and giggling at the end of that one session.
That's amazing. Yeah, I wish I'd seen that.
Well, we'll give you a chance to see that. Maybe we'll even figure a way to bring some of that live stuff into the podcast.
That'd be nice. We'll have to figure that one out. Yes. Now, going back to resistance, I've been taught about resistance in my training quite a bit, and resistance, the way I have been taught, has always been about it's always going to be there, and you're going to have to address it constantly as you work with your patients. You have to name it, you have to talk about it, you have to, and so on, or sometimes you have to, confront it.
Yeah.
But maybe it's not what some other clinicians may have thought it is. So what is resistance?
Okay, well, I was at a Stanford faculty meeting of the voluntary faculty about, say 6 or 7 years ago, more or less. And this idea of resistance came up, and that we're supposed to teach the psychiatric residents how to deal with resistance.
Uh-huh.
And so I raised the question. I said, why don't we have a memo? Because I've been hearing that word resistance ever since I was in training, and no one ever told me what resistance is. And there's probably different kinds of resistance. And why don't we let's exchange emails, and I'll make a list. We can make a list of, say, the 3 most common forms of resistance or whatever.
Sure.
And then we can distribute that to the residents so they don't have to spend years and practice understanding what resistance is. And then I said, maybe we could even get methods to treat each of the common forms of resistance. Everyone said, oh yeah, we've got to do that. And so I waited for the emails to come, and nobody sent out any emails saying what resistance was or what they thought resistance was. And after 3 months, I just kind of gave up on the thing. And then I had a dream in the middle of the night. And I saw that there were 8 common kinds of resistance in 2 categories.
You saw that in a dream?
It came in a dream. In the middle of the night, I got up and I wrote it down. And that has revolutionized my practice and my treatment and teaching as well.
So say that, and you said there's 8 kinds of resistance?
Yeah.
Okay,
Yeah, 8
so
common.
is that clear? Okay, what is it?
Okay, well, first you have to understand the two styles of resistance, and then there's 4 versions.
Okay.
4 times 2 is 8.
Okay.
The 4 targets of resistance would be the resistance the depressed patient has versus the anxious patient versus someone with a relationship problem versus someone with a habit and addiction. So that's 4 targets. And then within each
there's no other targets than those?
Well, that's the vast majority of what you see as a clinician. Some people deal with chronic pain or tics or neurologic problems or psychosomatic problems, but depression, anxiety, troubled relationships, and habits and addictions, that's probably 98% of what I see as a clinician.
All right.
And then within each of those categories, you can have something called outcome resistance and process resistance. So there's outcome and process resistance for depression, outcome and process resistance for anxiety, for relationship problems, for habits and addictions. And so that 4 times 2 is 8. And those 8 forms of resistance are all completely different from each other. There's no overlap at all.
So what's the difference between process and outcome resistance?
Okay. Outcome resistance, the way to think about it is the patient doesn't want a positive outcome from the therapy. So in other words, the patient who is depressed, although they come asking for treatment for depression, there's a powerful part of them that doesn't want to become undepressed. The same with the anxious patient, is worrying, public speaking, anxiety, worrying about the family, but there's a powerful part of that patient that doesn't want to let go of the anxiety.
Okay. Why not?
Well, there's 4 different forms of outcome resistance, so there's 4 different answers to the question, but let's take an easy one first, that's easy to understand, the outcome resistance, say for habits and addictions.
Okay.
Let's say you have a new patient who's referred in for alcohol problems, alcoholism. He got a DUI ticket for driving drunk, so the judge has ordered him in, and his wife says he gets drunk every night and blacks out and sometimes gets violent and can't remember what he's done, and his doctor says he's warning him that he's run into liver problems. And so the way I think about outcome resistance is to say to the patient, let's imagine there's a magic button right in front of you, and if you press that magic button, you'll be instantly cured with no effort at all. You'll never take.
Don't you wish?
You'll never have another drink of alcohol, and you won't even have to go to AA. You'll never have to come back and see me again. Just press it right now, and you'll be instantly cured of your alcoholism. Will the patient press the button?
Of course.
Well, I don't think so, because and he wouldn't too, because in this case it's easy. Why do people drink?
Because they want to get drunk.
Yeah, exactly. And so for him, he doesn't see the alcohol as a problem. He sees it as a solution to his problems. He sees it as the only source of pleasure and satisfaction in his life, in all probability. The reason the outcome resistance for habits and addictions is because habits, whether it's procrastination or drug use or overeating, is an enormous source of pleasure for the person, and so they want
or a relief. A lot of people do this for relief. It's no longer a pleasure, but it's more like the bad things go away.
That type of thing. And so that's pretty easy for the layman and for therapists as well to understand. Outcome resistance for habits and addictions. Now, what would process resistance be for a habit and addiction? Well, I often say in workshops, how many of you here would like to lose some weight? And, 2/3 of the hands go up. Then I say, no, that's incorrect. You don't want to lose weight. Losing weight is one of the suckiest things in the world. There's only 2 things you can do to lose weight. What are they?
Diet and exercise.
Right, and nobody wants to diet and exercise. Come on, what do you want for lunch after our recording today? You want some sliced carrots, or you want something tasty, do you see? And we hear about the runner's high. And I say, how many of you have heard about the runner's high? And all the hands go up. I say, there is no damn runner's high. It's just a fraud. I ran 12 miles uphill recently trying to get a runner's high. and all I got at the end was tired. I don't enjoy running. Now, some people do.
I think some people do. I think that it's true for some people.
Yeah.
And that may not be the majority.
Right, but the people who were overweight would probably rather be eating Doritos and watching TV than getting out and running, particularly if it's cold or rainy or whatever. So that's process resistance, and what it means simply is you may or may not want the good outcome. Maybe you'd like to be thin and attractive and lean and in good shape. But are you willing to pay the price to go through that process of dieting and discipline and exercise? The outcome resistance for habits and addictions is you have to give up your euphoria that you think you're entitled to this pleasure, and you have to give up the greatest source of pleasure. And then the process resistance you have to is discipline and deprivation.
Oh, wow! So I want to make sure that I get you, and I can summarize what those two types of resistance are. The outcome resistance is something that is maybe not very intuitive, but in fact that the patient does not want to get better for a variety of reasons.
Right.
They don't want the outcome that they're seeking in therapy.
Yeah, right.
And the process resistance is they don't want the pain that it takes to get there.
Or whatever the price is going to be. That's right. Absolutely. And that's a good, simple way to look at it. Now we can work our way up and talk about relationship outcome and process resistance.
Okay. All right.
I sometimes make controversial statements because I see things
I love when you do that.
Differently. Well, sometimes you do. Sometimes
you're going to get some hate mail too.
At me, and for good reason. But my reading of the outcome literature on relationship therapy, whether it's couples therapy or treating people individually who have, say, a conflict with their boss or their brother or something, that it's not favorable. All of the current forms of couples therapy pretty much have been tested, and in controlled outcome study, they do a little better than placebo therapy, but not a whole lot.
Well, I like to say that in physics, a problem with more than two bodies is a hard problem.
Oh yeah,
and if it's hard in physics, imagine in personal relationships. So when you have three people in the same room,
absolutely, it's very tough. And I think the reason for that is because most couples therapists or most therapists who treat relationship problems aren't taking into account outcome resistance as well as process resistance. Mm-hmm. They're trying to help the couple developing a more loving relationship. So you see books like Helping Troubled Couples Change, or Getting the Love You Deserve, or The Love You Need, or whatever. It's all these ways of achieving intimacy, but then you have a troubled couple and it doesn't work.
Yeah, you're making the assumption that if they're in your office, it's because they want love.
Exactly. And usually nothing could be further from the truth. And when I first started treating troubled couples, it was frustrating to me until I discovered the whole thing of outcome and process resistance. I went to all the workshops on couples therapy. I have a whole long bookshelf, a couple of them filled with textbooks on couples therapy, and I tried all these techniques, and I was just shocked at how ineffective they were. In fact, I was even planning to write a book after feeling good. I had a $150,000 advance to write a book on couples, and I even wrote it. It was called Couples in Conflict, Couples in Love, and it was kind of using cognitive behavioral techniques to treat troubled relationships. The idea was, it's so good for depression. The research is showing it's great for depression. So
must be good for that too.
Yeah. And I sent it to my editor, Maria Guarnaschelli, in New York, and she called back the next day. Darling, this is fantastic. This is going to be a #1 bestseller. and I was it sounded so good on paper, but I started noticing that it wasn't working with real couples. And I said, Maria, let's wait till I get 6 months, and then I'll get more vignettes to put in the book, and I'll spiff up the draft, and then we'll release it. And then it was 6 months later, and I
can get your vignettes.
Yeah. And I had tried it on about 50 couples, and I was 0 for 50. Uh-huh. The technique simply did not work. There were communication techniques, finding out what your partner wants and doing those things for him or her, or all these clever sounding ideas, and they would work in the office and then go home and beat each other's brains out. Well, I finally believe I figured what the missing link is. That the outcome resistance on relationship problems is that the person probably doesn't want to get close to the person that they're in conflict with. They don't actually want a loving relationship. And the way I show this in workshops is I say, how many
it's rather
of you...
shocking.
Yeah, I say, how many, and we can do it with our listeners now, how many of you who are listening to this right now know at least one person who you don't like, who you resent, who at any time in your life, now or at any time, and all the hands in a workshop go up, and I can see the listeners now. There's all three of our listeners have their hands up.
That's right. Yeah, I can see them. We have this ESP, so we can...
it's you and me and the one person who's listening.
Exactly,
There's three of us. And then I say, now imagine there's a magic dial right in front of you, and if you press this magic dial, that person who you so deeply resent will instantly become your best friend in the whole world. And if I got 200 people in the audience, maybe 3 or 4 hands will go up.
Yeah.
And then I say to the audience, now I just gave you a choice between a loving, joyous, fulfilling relationship and a hostile, troubled, abusive one. And what did you choose?
Choose the hostile one.
Yeah, and I said, that's not necessarily bad. Maybe some people aren't worth the investment of time and effort, but that's the thing. Most people with troubled relationships don't actually want to get close to the person. They're just there in the office maybe to tell you what a loser their sister is, or their neighbor, or their husband, or their wife. And this is very hard for therapists to comprehend at first because we're so idealistic. And we see you've got a troubled relationship and I've got all these tools and I'm going to help you make it a loving one. And then you run into resistance. So that's outcome resistance for relationships.
Yeah. Interesting. So the outcome resistance for relationships is somewhat different from the outcome resistance for habits and addiction.
Totally different, yeah.
And so we're using the same word, but it really refers to different phenomena. Different phenomena. Interesting, yeah.
Yeah. And then you've got process resistance for relationship problems as well.
Yeah, yeah. I can imagine those, yeah. Go make friends with your enemy.
And I'm sure you're about to ask me about process resistance for relationship problems.
Yes.
So to bring that out in workshops, and we can ask the people, our one listener, how many we've got, think about that person who you so deeply resent, who you don't like, who you have a troubled relationship with, and think about what they're doing. What you don't like. Maybe they talk all the time, or it's all about them, or they're selfish, or they're argumentative, or stubborn, or they pout, they have to get their way, they exploit other people. And now ask yourself this question and answer it from your heart of hearts. Who do you think is more to blame for your problem with this person? Who's the bigger jerk, you or the other person?
Well, I'm kind of a rational person. It takes 2 people to tango.
Yeah.
So, it's 50-50.
Yeah. Well, most people don't answer 50-50. In an audience, they say, who's the bigger
jerk? Well, it's them,
they,
of course.
They say it's the other person.
We're educated.
Yeah. We know 50-50 is not my answer either.
Okay, all right.
But at any rate, people say it's the other person's fault. They're the bigger jerk. And 90% of people with relationship problems will tell you it's the other person's fault. And they totally believe it. It's 100%.
Yeah, I've seen that, yes.
And then I say to the workshop audience, what is the prognosis for helping someone with a troubled relationship when they're saying it's someone else's fault? And then the answer to that is 0. And that's the process resistance. I know of no tools in the world, and hopefully maybe we'll figure some out in my Stanford Tuesday training group. That's what we're going to be trying to do next week, actually. But right now, I know of no tools that are powerful enough to help somebody who's blaming others for the relationship problem. So that's the thing that has to be melted away one tool or another if you want to overcome the process resistance. So those are two very intense forms of resistance for relationship conflicts.
See, so the process is to actually stop blaming.
To stop blaming and to focus entirely on pinpointing your own role in the problem, and to focus all of your energies on changing yourself rather than trying to change the other person.
Well, I've always done that with the people I've seen individually, because my response I was always being, this person is not here in the room to work with, and the only person we can work with is you.
Yeah. And so you have actually a better chance, in my experience, if you don't have the two people at the same time. Couples therapists trying to say you have to have both at the same time.
Yeah.
My point of view is if you don't have both, you have a much better prognosis, because you can form a warm relationship with the one person, and if they're willing to look at their own role and focus on changing themselves, the moment they change, in almost every case, the other person will change.
Okay. Well, I have more questions on this, but I want to keep this podcast to a reasonable length. So maybe you want to talk about the other targets for resistance?
Oh, yeah. Anxiety, the outcome resistance has to do with magical thinking in pretty much every case. And what that means is that although the patient with anxiety is in tremendous pain, worrying, and fearful, he or she almost always believes, and probably always believes, that if the anxiety disappeared, something terrible would happen.
Yeah, like it's a protective mechanism.
Yeah, that it's gonna protect you, and all of the treatments now for anxiety are not taking this into account. You have cognitive therapy for anxiety. You change the distorted thoughts, or behavioral therapy for anxiety. You use exposure. Yeah. And those two tools are very powerful, but if you don't address the resistance, those tools will have limited effectiveness. And the other side of the coin is, if you learn how to melt away the resistance of the anxious patients before you use these other tools, you'll have a vastly greater success rate.
Okay.
Let me see if I can give you an example of outcome resistance for anxiety. Let's say a woman comes to you, as I've had many with chronic worrying. I had a woman came at 53 years of failed therapy for chronic worrying.
Yeah.
And patients who worry typically worry all the time. She was worrying about her husband, her sons, her, the family members.
That's what we call generalized anxiety disorder,
Exactly. Or it could be a younger woman who's worrying about her children and thinking, gosh, they'll go to a high school party, they'll get drunk, they'll be killed in accidents, and she's worrying all the time about her children as well. Mm-hmm. And then if you say to the patient, here's a magic button, if you press this magic button, your anxiety will instantly and totally disappear with no effort on your part. Will you press that magic button?
I know that the answer is they will say yes, but they should say no or something.
Yeah, because what would happen, if she presses that magic button?
She won't be able to worry about her son.
And then what's going to happen?
Something bad's going to happen.
That's the magical thinking.
Yeah.
You see, from our point of view, the worrying is a brain disorder. That's the way we're trained to think about these things. But from her point of view, her worrying, or his worrying if it's a man, is her love for her family. And she believes that this love is protecting them.
Yeah.
And that's what a mother does. And if she presses the magic button, then she stops worrying about her children. It's like she stops loving them in her mind, and then they'll end up being killed in an automobile accident after drinking at a party. Now, the outcome resistance for each kind of so-called anxiety disorder is a little different, but it's always this exact same thing of magical thinking. If a patient has obsessive compulsive disorder, so let's say I treated a psychologist who had pretty severe OCD. She had good insight. She's a lovely woman, very, very smart, but she washed her hands 50 times a day,
Mm-hmm.
and her hands were just chapped and looked terrible. And she wanted help with that. And I said to her, well, just call her Sarah to disguise her name. If you press this magic button, you'll be cured. And she said, well, sure, I'll press that magic button. I said, well, let's examine that. When you wash your hands, what is it that you're afraid of? And she said, well, I'm afraid of contamination. She says, it's irrational, I know, but emotionally I believe that there's this contamination in the air. Okay, well, let's say that you become my patient, and my first assignment to you will be to stop washing your hands, maybe just once a day, or I might even tell you to go several days without washing your hands to get over this. What do you think is going to happen? She said, oh, that has to be awful. My hands will get contaminated. And I said, well, then what do you think is going to happen? She said, well, then I'll touch my children. Okay, and then what? This is called the what-if technique.
Yeah.
And what are you the most afraid of? She said, well, then they'll get contaminated. Okay, and then what if that happens? What are you afraid of? She says, well, then they'll die of leukemia. And she said, I know, it sounds crazy, it sounds irrational, but emotionally I believe it to be true. Yeah. So on the one hand, she's asking for treatment, but on the other hand, there's a part of her that clings to the obsessions and the compulsive rituals she was involved in, washing her hands. She had other rituals as well, because she believes that she's magically preventing some horrible thing from happening.
Yeah, those so-called negative emotions is something that I've always been aware actually are serving a very positive role. And I always remind my clients of that if they're feeling quote-unquote bad, it actually is there for a reason.
Yeah, and now we can bring those reasons to conscious awareness and really sell the patient on maintaining the symptom for all the good things it shows about them and all the benefits. And paradoxically, this tends to melt away their resistance. So we should probably move on, but the outcome resistance for panic attacks is a little different, and for PTSD is a little different, and for phobias is a little different. Mm-hmm. But for hypochondriasis, people go to doctors all the time worrying. But it's always this issue of magical thinking, and if you don't address that, you'll have a more limited success rate.
Yeah.
Then there's process resistance for anxiety.
So what would that be?
Well, what is the one thing that every anxious patient will have to do to be cured?
Well, they really have to face the things that they're anxious about.
Exactly. And what percentage of anxious patients will want to use exposure to face their fears?
Well, most people I've worked with, they don't really want to go there.
Yeah. No anxious patient really wants to do that. I've had myself 17 anxiety disorders. When I wrote my book, When Panic Attacks, I started counting up. Gosh, I've had the fear of dogs, bees, horses, blood, heights, public speaking. The list goes on and on. That's why I love treating.
I thought everyone had a fear of public speaking.
Well, probably most people do. But that's why I love treating anxiety, because whatever the patient has, I can say, oh, I had that too. I know how sucky that is, and I can show you how to defeat that thing. So I've had to use a lot of exposure myself, but the patient isn't going to want to use exposure. It's terrifying. One of my fears was blood, and I never should have gone to medical school. I was kind of
that's kind of amazing.
I was told to go to medical school. I wasn't a pre-medical student in college, but one of my advisors, I was going to become a psychologist like yourself, and one of my advisors said, no, don't go to medical school, become a psychiatrist. That's better, because drugs are going to become so important. And I said,
which was true, actually.
Yeah, it was true. But I said, but I'm not a pre-medical student. I've never had a biology course. And he said, you can talk your way into anything. So I went to medical school, and I had this blood phobia, and I never should have been in medical school. But the way I got over my blood phobia, I went up to volunteer in the emergency room of Highland Hospital for a month before I was an intern, and so because I used to cut medical school classes and everything. The whole thing at hospitals and needles and blood, I didn't appeal at all. And so I volunteered. They said I could work there for 15 hours or 12 hours on, 12 hours off, 7 days a week for a month and get over my fears and learn some medicine.
So you did your own exposure.
Yeah. And the first time
That seems to contradict what you said about patients who don't want to
Well, but that's the motivation thing, you see, because at that point, I really wanted to become a doctor because I had an MD degree. I didn't even bother to apply for an internship after medical school because I didn't want to be a doctor. I had the fear of blood and gore and all of that. And I was, actually, my wife and I became homeless people down in the area of Monterey down there. We used to hitchhike around and sleep on people's floors, and
wow.
And my wife was pregnant, and I used to counsel people for free on beaches and coffee houses, but people didn't take me seriously because
you were a bum.
Yeah. So, gosh, if I went back and did my residency, I still wouldn't know anything, but people would think I knew something, so they'd pay me to talk to me, and that's actually why I decided to do my residency.
Well, you know the joke, what do they call the last graduating student of a medical class?
What?
Doctor.
Oh, yeah, right. That was me. But the first day I was there in the emergency room, this patient came in with sirens and police, and apparently he was a bomber and his bomb blew up. He was going to blow up the Oakland City Hall, and his bomb blew up in his basement, and he was just all covered with blood, and they rushed him into this trauma room, and they were sticking needles in him, putting in IVs, and this nurse grabbed me and said, "Hey, you've got to help." And I said, "What did you want me to do exactly?" This is exactly my specialization. She handed me a toothbrush. She said, "Here, you get busy with this." And I said, "You want me to brush this guy's teeth? Does he have awful breath or something?" I said, "He's in a coma." And she said, "No, look at these black spots in his tissue, his flesh. It's gunpowder. That'll poison him to death. You're going to take this toothbrush and put your hands in his bloody tissue and scrape out all of that gunpowder." And it was so anxiety-provoking, but I couldn't say, tomorrow will be a better day. There was intense pressure to save this man's life. And I started doing it, and for 15 minutes, my anxiety was 100 out of 100.
Yeah.
But I just had to keep doing it. And then all of a sudden I had the thought, wow, these doctors and nurses here in Highland Hospital are like geniuses or something. They're so kind also. They're probably going to save this guy's life. They're so skillful. And I'm a tiny little part of that medical team. And by the end of this month, I'm going to be kind of like a real doctor. And it blew my mind. In that instant, my anxiety totally went from 100 to 0. And that month, working at Highland Hospital was one of the best months of my life. But that's exposure. But it also shows the importance of motivation.
That's a great story.
Because I was like 28 years old at that point, and I had this since I was a little boy, and I just dealt with it through avoidance because I didn't have the motivation to overcome it until that where my career really depended on that. So
you're really putting into balance how the motivation is what helped you overcome your process resistance.
Yeah, and that's what has to be done. So we've also developed tremendous methods for dealing with the patient's process resistance. But anyway, that's outcome and process resistance for anxiety.
Yeah.
And
how about depression?
Depression, the outcome.
Often, people who come to therapy, they seem to have both anxiety and depression.
Yeah. Sure. Then you may have a couple different forms of resistance going on simultaneously. You often see that. The outcome resistance for depression is kind of a Buddhist kind of thing. It has to do with non-acceptance. There's something about yourself that you don't want to accept. when you're depressed, and so
self-judgment.
Right. And so you're telling yourself, I'm no good. I shouldn't have made that mistake. I shouldn't have screwed up. I should be better than I am. And I'm sure the people listening to this podcast, they probably have moments of self-doubt as well.
Yeah, just like you, when I work in a room with an audience and I ask people to raise their hand, have you ever had that thought that you were less than, or that you were judging yourself? And of course, everyone raises their hand.
Yeah, and the way and the solution to that is to accept yourself with your warts and your flaws. And to lower your standards. But the depressed patient doesn't want to do that because you're afraid you'll be settling for second best. And so overcoming depression and actually involves what the Buddhists call the Great Death. And you actually know more about this than I do because you're an expert in Buddhism. I'm kind of a bullshitter in Buddhism.
I'm not really an expert, but
it's the death of the ego, the death of the self, to give up on trying to be something that you're not. Karen Horney was, I believe, a feminist psychiatrist of the 1950s, and she wrote about the tyranny of the shoulds. The reason I know that is because my mother read one of her self-help books in the 1950s and found it helpful. I think my mother struggled with episodic depressions. In fact, I know she did.
Yeah.
But the way Karen Horney put it was that we have these two selves. There's the ideal self, that the self we think we're supposed to be, this flawless, wonderful human being that never gets angry and achieves great things, and all of this. And then we have our real self, which is so broken and flawed and filled with failures and shortcomings. And so we, instead of accepting our real self, we keep saying, I should be this ideal self.
We try to merge the two.
Right.
Isn't that what the superego does?
That might have been Freud's way of talking about it, and I think that would be an excellent way of saying it, yes. So that's outcome resistance. And I can give a dramatic example of that in just a moment, if you like. But
yeah, I'd love to. It looks like we may have to split this podcast in two parts because I know that the agenda setting part of your model is really like the meat of it, and I don't want to shortchange it. So we probably should conclude with the resistance targets, and then we'll talk about what you do about it in the next podcast. How's that?
Sure. And that sounds great.
So you're going to give an example,
well, do you want to give the example now or in the next podcast?
No, how about you do it now? Yeah.
Oh, okay. Great. A dramatic example of the resistance for the depressed patients.
Yeah.
We in my program in Philadelphia, we had a kind of a free residential treatment program. Our city was our hospital Presbyterian was in an inner city kind of a drug warfare area, and we had a lot of homeless people and street people and who we treated, and we treated them in groups, and with many groups each day. So each patient would get a lot of therapy every single day until they were symptom-free. And I remember after I got the program set up, then I would go in from time to time to run the groups and sit in on them and see how, in those days we were calling it cognitive therapy, how did that do with this very challenging population. A lot of them couldn't read or write. And it was actually, they were the easiest people I ever worked with. But this one day I had a fellow in my group, and I was told ahead of time by the nurses that he was a local kind of a gang person and a prominent heroin and cocaine dealer, and that he was exceptionally violent, and he was admitted for suicidal depression. And he had been challenging me during the group and kind of shouting four-letter words and kind of sabotaging the group. And
that must have been unsettling for you.
It was, because the nurses said, "Don't challenge him, or he may kill you." He's known in the neighborhood to be pretty bad guy.
Yeah.
And so I did a demo with a patient, went very well, and she recovered quickly. The technique just happened to work, and I was talking about self-esteem, and then he started, shouting at me 4-letter words, and, self-esteem is a crock of BS, and all of this. And he said, you can take your self-esteem and stick it up your A, and stuff like that. And I think he said, you're effing A. But then I kind of won him over by saying that what he was saying was what I was saying, and that he could probably help me teach the group. I said, there's no such thing as self-esteem. It is kind of a myth. And I said, this is actually what I'm teaching today is based on Buddhism. And you seem to know this stuff already, that, you can't achieve self-esteem by achieving a lot or being loved or following the rules of society. I said,
and he didn't see that as sarcastic.
Well, no, he didn't. I said, Benny, what you're saying is really similar to what Buddha said 2,500 years ago. I said, tell me, Benny, were you raised as a Buddhist? And he was like, from South Philadelphia, Italian district. He's all covered with tattoos. He's this young, evil-looking gang member. And he says, I'm no effing Buddhist. I'm in the goddamn mafia, if you want to know the truth. And then I said, well, Benny, Buddhism and mafia, those are very similar constructs. And then he got all excited and he rushed into the circle. He hadn't been willing to sit in the circle with the patients. He was just pacing about in the room, looking at me in this hostile way. So he finally came in and sat in a chair right in the middle of the circle. And then he said to me, okay, Doc, if you're so smart, let's see if you can find any distortions in my negative thought, because we were talking about cognitive distortions. And I said, well, I'll be glad to, Benny. What's your thought? And he said, I'm a hopeless case, and there's nothing you can do about it. So I wrote it on the flip chart, and I'm trying to think, how am I going to help this guy? And I thought, maybe he's pretty oppositional. He's pretty hostile. Maybe we need a motivational technique. And one of the many motivational techniques I've developed is called a paradoxical cost-benefit analysis. And so I said to him, well, Benny, I could easily prove to you that thought is a distorted false thought. But before we do that, maybe we better see if there's some advantages for you in believing that. Maybe we can make a list of advantages. And I put a cost-benefit analysis on the flip chart. Advantages on the left and disadvantages on the right.
The standard cost-benefit, yeah.
Yeah, so I said, what are some benefits of telling yourself you're a hopeless case? Benny, the way I'm thinking about it right now, there's tons of them, Benny. That's one of the best things you could tell yourself. He says, Doc, you don't know what the F you're talking about. I've been through every drug abuse program in Philadelphia, and I've flunked out of every one of them. A lot of them I flunked out of 3 or 4 times. And I can tell you this, Doc, I'll be dead in 2 years. You can count on that. You put that in your right-hand column. So I put dead in 2 years on the flip chart. And I says, Benny, you're just not getting it.
That was a cost, not a benefit.
Oh, yeah, cost, disadvantages. The right-hand column. There was nothing yet in the advantages column. I said, Benny, you're still not seeing it. And then I turned to the group, and we can ask the listeners right now, what are some advantages for Benny in telling himself, I'm a hopeless case?
Yeah, we want people to ask people to pause the recording and think about this for 15 seconds.
Or even a minute or two. So see how many advantages you can think of. Just turn off the recording and just ask yourself, if Benny tells himself, I'm a hopeless case, what are the benefits? Turn it off now, and we'll have a moment of silence, and then after that, we'll continue and tell you what the group came up with. Okay. Well, and I do this often in workshops, and people come up with a list. They always start out by saying, "Well, it's easy." And I said,
and it's familiar.
Yeah, I've
always done it.
Yeah, easy and familiar. And I said, here, Benny, we're we're all working in our workbooks and learning about cognitive distortions, and if you say you're a hopeless case, you don't have to do any of this hard work. And then someone said he can get stoned all the time. And I said, yeah, Benny, I hear you have the best cocaine and heroin in Philadelphia. I said, I've never had those drugs even once, but you can just get high all day long. It must be tremendous. And then people said, let's see, what are some other benefits? We came up with about 15 of them. Let's see.
Well, he may have formed an identity, a view of himself, and that's conformant to his identity.
Oh, yes, I said, yeah.
He would be denying himself otherwise.
Yeah. I said, Benny, you have quite an identity from this. You have a lot of prestige. You can ride your motorcycle, you can deal your drugs, you've got a lot of money. Money, there's another big one.
Yeah, money.
And the nurses told me you're the big man in the neighborhood, that you have tremendous prestige. Everyone is afraid of Benny. Everyone bows down to Benny. They said, you watch out for Benny in that group. Benny, right now, you're the most important person in here. This gives you tremendous prestige.
Yeah.
And then someone said he's very powerful.
Yeah.
And I said, yes, Benny, you're very powerful. But how many psychiatrists have you defeated so far? And he says, at least 13. And I said, what's the name of the psychiatrist you're going to defeat today? And he says, Dr. David Burns, no doubt about it.
Yeah.
So we got on a roll, and then he started adding, and he says, I get laid all the time. So he's this handsome bad boy, right?
Yeah, right.
And so he gets unlimited sex, so he can get high all the time. And then someone says he can be irresponsible. He doesn't have to follow the rules of society. And I said, that's right, Benny. I said, Benny, you are kind of like James Dean. You're like a cultural hero. You're a handsome bad boy with a motorcycle jacket. And you make the rules, and you break the rules. You don't have to follow any rules. I said, in fact, Benny, you're kind of the man I always wanted to be. I think your lifestyle is kind of appealing in a way. In fact, what I've heard, Benny, is when you don't like someone, you just beat the shit out of them. And Benny, that's something I've always wanted to do, but I've never been able to because I was a minister's son, and I've had to be so damn nice to everybody. What's it like, Benny?
Yeah.
Is it as good as they say? He said, it's wonderful. So I added the joys of violence. So we're all getting on the roll, all these great things that are going to happen to him. I'm sorry I bumped the table. If he says, I'm a hopeless case, and then I just reflected it back to him, and I said, Benny, 20 minutes ago you asked if I could help you with this thought that you're a hopeless case. But look at all the benefits for you. It's easy. It's familiar. You can't fail. That's another one. You don't have any expectations.
Yeah.
You won't be disappointed. You can get high all the time. It gives you tremendous prestige. You're the big man in the neighborhood. Everyone's afraid of you. Everyone bows down to you. You get laid. You have tons of money. You're a very powerful guy. You can do whatever you want, whenever you want. You don't have to follow the laws of society, the rules. You make the rules. You're kind of like a prince or a king. So then I said, tell me, Benny, I'm a little confused right now. It seems to me like these are all the good things in life: euphoria, power, love, sex, money, identity, prestige. I said, it seems to me like you've got a pretty good thing going. Why in the world would you want to give that up? And when I said that, I became Benny. I was no longer the shrink, the healer, the helper. And at that moment, I could not see any reason for him to change. I really couldn't.
Yeah, you stepped into his shoes. Yeah.
Yeah, and so now I've become the resistance. And when you become the voice of the resistance, instead of trying to sell the patient on change, I'm trying to sell him on remaining the same. And that's scary for therapists to do. But if you do it skillfully, and it has to be sincere, and I saw this stuff, and it has to be done with kindness. I actually liked Benny, and he could pick up on that. He knew that.
Actually, I'm beginning to like him too.
Yeah,
He's not like
he was
this...
kind of a neat guy, really.
Yeah.
And then he looked up to me and softened for the first time, and he says, "Doc, you read me like a book." And then he said, "Can I talk about something I've never talked about even once in my life?" I said, "Sure, Benny, you can tell us anything." And then he said, "When I was a little boy, the person I loved most was my grandfather." And then he explained that his grandfather was a lot like him, that he went into deep depressions, and that I think he said he was involved in the same line of work as I am. And he said he was about 8, and he loved his grandfather because his grandfather was the only one who talked to him and spend time with him. He said he'd sit on the floor, and his grandfather would sit in his chair, and they would talk. But he said this one time that his grandfather was talking in this dark way, and Benny was saying he was getting scared because his grandfather had a shotgun in his lap, a sawed-off shotgun. And the grandfather was talking like there was a problem with the family, and there was going to be no way out. And then he kept saying to me, "Doc, wasn't that wrong of him to talk to a little boy? I loved him, and I thought the shotgun might be loaded." I didn't know. And he said then, and grandfather put the shotgun in his mouth, the barrel of the shotgun, and then he said, and Doc, he pulled the trigger and blew the back of his effing head off. And then he just broke into sobbing, uncontrollable sobbing, and tears flowed, and snot went down his nose and was coming out of his nose, and a lot of people in the group started crying at that point. There were tears in my eyes as well, and he, after a few minutes, he kind of pulled himself together, and then he said, "Doc, do you know, I wouldn't show you my workbook earlier in the group. I'd asked to see his scores on the depression test that we were testing the patient several times a day, and they would shout out their scores in the group, and we'd write them down. And
he wouldn't.
He wouldn't give me his scores. He threatened me when I asked to look in his workbook. And then he looked up to me and says, "Doc, do you know how I wouldn't show you my workbook?" It was called the 10 Days to Self-Esteem. It was the workbook that we gave out to all of the patients who came into that program. And I said, "No, Benny, I don't know why you wouldn't let me see your workbook." And he says, "I'm going to tell you why, Doc." He says, "It's because I can't effing read or write." And I was so ashamed. I didn't want the other group members to see that about me. And then he started sobbing again.
Wow.
And that's paradoxical agenda setting.
What a story. It's like, he really, melted into the palm of your hand.
Yeah. Now, someone who's that severe is going to need an awful lot of work, and if they're to have any hope of change, the prognosis would probably still be pretty grim. But for patients with depression and anxiety, and even severe depression and anxiety, not only does the patient suddenly eat out of your hands, but it opens the door for incredible high-speed change at speeds 10 years ago I never would have thought possible.
Now, that was the outcome resistance for depression.
Oh, yeah.
We don't have a lot of time left, but if you could maybe briefly talk about the process resistance
for
depression.
That's a quickie. I mean, we talk about it a lot, but in a nutshell, it's written psychotherapy homework and other kinds of psychotherapy homework. Every patient with depression must agree to do the psychotherapy homework between sessions. I did a study that I published in probably the top psychology journal for clinical research, Journal of Consulting and Clinical Psychology, in the 1990s where we measured for the first time the causal effect of psychotherapy homework on recovery from depression.
Yeah.
And it was a massive effect. And this was 2 independent studies we did, about 200 to 300 patients in each group. So there were about 500 patients, 450 or 500 total. And what the data showed, just in layman's terms, was that every patient who did reasonably consistent psychotherapy homework improved greatly or recovered completely. Virtually every patient who refused to do psychotherapy homework failed to improve. Many actually got worse, and many of them just dropped out of therapy.
Well, that's a little bit intuitive. The more work you do, the better you get.
As well as it reflects motivation too.
Yeah.
But you're practicing the tools you're learning in therapy. So that's the process resistance. So should we do a quick review and then stop the 8 forms of resistance?
Yeah. So why don't you go through this?
We'll go through in reverse order.
Table mentally.
We'll start
in fact,
from
maybe we
depression
should put this in the show notes so people have a list of what they are.
Yeah, we can easily do that. Depression, the outcome resistance, has to do with non-acceptance. The process resistance has to do with psychotherapy homework.
Yeah.
For all anxiety disorders, the outcome resistance has to do with magical thinking. The belief that the anxiety is going to protect you from some awful thing that's going to happen to you. The process resistance is exposure. For relationship problems, the outcome resistance is simply not wanting to get close to the person you're in conflict with.
Yeah.
The process resistance has to do with giving up blame and focusing instead on pinpointing your role in the problem and focusing all of your energies on changing yourself.
Yeah.
And for habits and addictions, the outcome resistance is giving up a source of joy and pleasure, something we think we're entitled to. I've had a hard day, so I deserve that drink, or I deserve to eat this stuff that I love so much. That's my pleasure, my reward for an otherwise difficult life. And then the process resistance is doing something that involves discipline and deprivation.
Well, that's a very clear summary. I think that this will clarify this for our listeners who are not familiar with the model, and we'll see if we can put something online also. So essentially what we've seen today is, what resistance is, the different targets for resistance, some of the things you've learned along the way as to, what's happening when people don't really want to get better. So I think in the part 2, what we'll talk about is, now that we know, what the process of resistance is, what do we do about it? So I think that will be our next topic.
Great.
All right. Well, thank you so much, David. This was very enlightening and definitely a very important podcast. Thank you.
Thank you, Fabrice. I appreciate it.
All right. Take care.